5. I think we'll go ahead and get started here. So welcome to the Workforce Development panel. I'm really excited to get going and introduce our speakers. First, I will introduce myself. So I am Emily Paff. I am an assistant professor at UNC Chapel Hill in the Department of Medicine. And my background is clinical informatics and specifically using EHR data to do clinical informatics. I'm much less on the bioinformatics side. I have been involved with our CTSA at UNC for the last 10 years in a variety of capacities. Most recently, I co-direct the Informatics Data Science Service there. And I also have been recently very heavily involved with the National COVID Cohort Collaborative, which is a very large network of EHR data providing centers that are trying to use data-driven research to manage the public health crisis we're all very familiar with. So I am very privileged to introduce the speakers who are going to be weighing in on informatics workforce development today. First, we have Dr. Carlton Moore, who is a professor of medicine at the UNC School of Medicine. He's associate chief in the Division of Hospital Medicine, a practicing hospitalist physician, and is board certified in clinical informatics. Dr. Moore is program director of the ACGME accredited UNC Clinical Informatics Fellowship Program and associate director of the UNC Institute for Healthcare Quality Improvement. His research interests include using NLP to identify clinical phenotypes, EHR usability evaluation, and using disease severity scores in EHRs to identify patients at high risk for adverse outcomes. We also have Bonnie Woods, who has spent the better part of her 25 years at Johns Hopkins supporting student information systems, but realized her true passion 6 years ago when she joined the School of Medicine's Institute for Clinical and Translational Research, where she leads the team approved by the IRB and Data Trust to extract clinical data from the EHR for research purposes. She obtained her EPIC Clarity Data Model certification and now serves as translator between research study teams and the technical team she manages. She is committed to helping researchers successfully navigate the clinical research life cycle, and publish their research to positively impact patients. And then finally, Michelle Morris is a senior software architect in the Department of Biomedical Informatics at the University of Pittsburgh. She has a BA in Applied Math to Computer Science from Northwestern and over 20 years of experience creating clinical and biomedical informatics solutions using EHR data, NLP, and ontologies. Michelle currently leads data harmonization work for the ACT network, chairs the ontology work group for the I2B2 Transmart Foundation, and has a lead role in data ingestion and harmonization for the National COVID Cohort Collaborative, where I've had the great pleasure of working with her. So thank you very much to our 3 panelists for being here. And with that, I'm going to go ahead and kick things off with our very first question. So just to give everybody an idea of where you're coming from, other than your brief bio that I just mentioned, can each of you briefly introduce the clinical informatics ecosystem at your institutions from both a faculty and staff perspective? And we can start with Dr. Moore.
Okay, so I'll share my screen. Okay, let's see. Can everyone see this?
Yes, we can.
Okay, great. Okay. So yeah, at UNC, I wear several hats. You know, I see in general my job as being kind of a mediator between the kind of the clinical world and the informatics and kind of data science world. So one of my roles is as program director for the Clinical Informatics Fellowship. And in that role, I supervise the fellows, and we're kind of embedded in the Information Systems Division, Services Division, ISD. And they pay for half of our fellows' salary, and then their home clinical departments and divisions pay for half their salary. And they work very closely with ISD data analysts and informaticians to do their projects, and actually they get experiential learning that way. Another one of my hats is as the associate division chief for the hospital medicine. And my big role there is for faculty who want to do quality improvement and research, is to actually help them navigate the system here. So we have basically a research side run by NC Tracks, that's our CTSA, and that's under the School of Medicine. And kind of our operational side, that's UNC Health, and that's Information Services Division. So helping them navigate to eventually kind of get data. It's kind of the center of the universe of what I do is the data and the data warehouse, and how to navigate the IRB and also the CDW Operations Committee to give researchers access to data in the data warehouse. And then as a kind of a shameless plug, actually, Dr. Paff actually just helped publish a Jamie article describing the government's structure of the Operations Committee. And just kind of the volume of actual requests that they actually have to address, and kind of the priorities and what they look at as far as when they evaluate an application. So so my job is basically to kind of help people kind of navigate this whole process, and also based on their research projects, let them know what tools are available. So for instance, NC Tracks provides REDCap, Clark, which is a machine learning program. Of course, I2B2. Immerse is actually a Google type search engine that you can use to search free text in the data warehouse, and Business Objects is mostly used for quality improvement efforts. Just to get an idea of how much data is in the data warehouse, we have the UNC system is fairly large. We have, I think, about 11 hospitals now. Most of their data is actually stored in the data warehouse. So it's a huge amount of information, and being able to help clinicians and clinician researchers kind of navigate the system and figure out what data they need and how to get it is a big part of what I do. We also interface with the Carolina Health Informatics program, and basically that's the program that they have postdocs and PhD students in biomedical informatics. Also, the School of Information and Library Sciences has graduate programs in information science. And then we also interact with RENCI, the Renaissance Computing Institute, and they do kind of a lot of big data type projects, and also linking large databases together, including like imaging studies and things like that. And because UNC is such a big system, we also collaborate with departments and divisions in the School of Medicine. So, in public health, nursing, and pharmacy. So, so I see myself as in general as someone who's kind of a mediator between clinicians who want to do research and informatics, and helping them kind of navigate through a UNC system that sometimes can be kind of complex. But I've been here long enough that I've kind of figured out how to get things done. And so I see my job is kind of to help facilitate and catalyze research and QI projects.
Wonderful, thank you. Bonnie, would you like to go next regarding Johns Hopkins?
Sure, I will share my screen. My presentation is a little more high level than Dr. Moore's, but I will try to do a comparison of Hopkins and services. So the informatics core is partially funded by the Institute for Clinical and Translational Research, which is NIH and CTSA funded. The ICTR has partners in University of Maryland, Baltimore, Morgan State University, Kaiser Permanente, and the informatics core itself, which I'll focus on today. You can see our suite of services. So federally funded research projects are with the FDA, CDC, NCI, and CATS. Dr. Christopher Shute is heavily involved in health IT standards development, serves as a leadership role in HL7 terminology and the Connectathon projects. And he's heavily involved in HL7 and the Odyssey vocabulary integration projects. And he has scientific oversight of the ICD-11 initiative with the WHO. We also support federated and centralized data integration projects that I'm sure most of you are familiar with, such as PCORI, Trinetics Act, and the Odyssey OMOP initiative. We also have a separate arm of the Informatics core, which is Informatics education. So we offer master and doctoral programs in informatics training. And finally, we have a program that is where I have most knowledge at the moment, is enterprise-wide clinical data support operations. So our team is responsible for extracting data from our Epic EMR. We assist with self-service cohort discovery. We offer natural language processing services. We participate heavily in our precision medicine initiative. We have a REDCap instance set up with the School of Medicine. We have specimen tracking systems that we offer. And we also have honest broker services. I am serving as the honest broker to the IRB and our data trust governance group. And like Dr. Moore, I spend a good deal of time serving as the translator between what the researcher requires to complete their project to what the IRB has approved and the technical requirements to implement or to provide data for the researchers. So we have a large team of both core team members who work for me and a program we call the adjuncts, where we support the access to Clarity and our other data sources, but the department pays the salaries of these adjunct team members. And in return, we provide the IRB oversight and support and mentorship. And it's a wonderful collaborative community. And I can talk about that in more detail if anyone has questions, but that's a success story with our group. So thanks.
Thank you so much, Bonnie. And then Michelle, would you like to speak about UPMC?
Me unmute. Okay. So I actually work for Pitt. So we are actually on the university side, and we get our data from the UPMC hospitals, which is about 40 hospitals. Our group is probably relatively small compared to UNC and Hopkins. We have about 18 faculty in the Department of Biomedical Informatics. I think they're mostly mid-career faculty. The most prominent work that we do in our area is around causal discovery. We have approximately like 11 developers, and we have had a little bit of an explosion of project managers lately. But all of our staff are grant funded, so no one's on soft money, hard money. So we do end up mixing around a bit. Lately, we've spent more time doing, like Bonnie and Carlton spoke about, data delivery. When I first joined the group, we did a lot more research development software, so it was a little bit different. So just trying to transition into delivering data to researchers, mostly EHR data, although we are doing a little bit, I guess, imaging and hopefully notes delivery coming up. So trying to think, we have at UPMC, they have a little bit of a complicated EHR ecosystem. We have Cerner for our inpatient, and for the pediatrics is a separate Cerner instance. And then we have Epic for our outpatient. In between all that, we still have Medipack for our ADT, and our notes are in a system called Mars, which was built here in Pittsburgh. So the way our work is that we get data from UPMC UNC, and we've built a data mart that kind of aggregates all of the data, and we use that data mart, Neptune, to service all of our CDMs. So we are also part of Pcori in the Path Network. We are in All of Us. So we have an OMOP instance, and we are the leaders of the one of the lead teams of the ACT I2B2 network. We also manage our PIT RIDCAP instance. For our CTSA, the informatics core is in our department as well. So I guess that's it.
Thanks, Michelle. So that's really good to know about everyone's sort of institutional background and the way things are set up. And it sounds to me like there's a lot of similarities, but also, you know, enough differences to make it so that you're each coming from slightly different perspectives when it comes to the informatics workforce. And, you know, I ask this question because I know that this is an issue that we have all felt very acutely recently, which is that it's not easy to find and retain qualified informaticians, whether you're talking about faculty or staff. It's really a challenge. And so I'm hoping that that you all can talk about some of the biggest challenges that your institutions are facing in that space, and as far as hiring and retaining faculty and staff in the informatics field. And I won't call on people, you can just sort of jump in if you have a response.
Well, I can start. I think that obviously the biggest issue is what you kind of hit upon, is that a lot of it's just like people can make so much money in the private sector. And so it's very, very difficult to retain, you know, faculty and staff unless you motivate them, unless you create a job environment that they enjoy working in, and that they think what they're doing is important and it motivates them. I mean, a perfect example is in my division of hospital medicine. It's interesting. We had a lecture on Wednesday about our salaries and how it compared to like the national average. And like, it was like a big deal that we were like 40%, we were in the 40th percentile. And like, that was supposed to be, that was like a big deal. That was like a big accomplishment. Like, you know, and it's because we're in academic medicine. Like, any of us can go out there and make so much more money, but we love our work environment. We love the people we work with, and we love what we do. We think what we do is important. And I think that kind of carries over into informatics, or pretty much any field in research. You're just not going to make as much money as you could in the private sector. And what your job has to motivate you. That has to be the thing that kind of keeps you doing what you're doing.
Right. I think that, you know, right now we're kind of in this atmosphere where we're just collecting data and putting data out. But I think we need to continue to do some more innovation, because those are the things that, you know, led me to leave private industry to come to a university. And so you want the projects to be very challenging and engaging. And it's hard to show, you know, what the end product is, because, you know, when you go to a private company, like, they're all about the product. And our product is really knowledge and increasing knowledge and building knowledge. And so we have to find ways to, you know, show that to, you know, new people who we're trying to attract, that, yeah, you're not going to end up with a widget that's real shiny at the end of the day, but you will be incrementally, you know, contributing to the improvement of health and healthcare. So I think we need to probably use that to sell a little bit more, because there is not, you know, the pay is bad, the growth potential is bad. Like, you'll be the same thing you were for the next 100 years. And so, but the benefits are good, right? Because we'll get off on the 20th and we won't work until January. So we have to sell the great benefits, and then hopefully the interesting projects. If we could continue to do interesting projects that are advancing science and advancing informatics, I think we can pull people in.
That's a really good point, Michelle, about trying to emphasize the reason that we come to work every day. My mentor and supervisor really framed the job for me when I switched from student information systems IT to healthcare is that my role could directly improve patient care. And it's true. I'm not a clinician, and I don't work on call and with the Epic system, but we work in research. So it's such an important position to be in, and then I try to emphasize that with those that I try to hire. But it is challenging because the salaries are not competitive. We recently offered a position to a candidate, and that person turned it down and took a job that was with a salary that was almost twice the amount that we could offer. So it's really hard to compete with that. And the other challenge too is that programmers are really not hard to find. And right now they're a little harder, but most of the time it's not so hard to find somebody with programming background. But what we really need is somebody who is a data scientist and a good data analyst. I think that's really hard to find, unfortunately. And then it's even harder to find somebody who's a good data analyst, a good data scientist, and has that translator capability, meaning they understand the clinical investigator's requirements, and they can tease them out and document them. And then they're able to take those requirements to programmers and help them build technical code or translate those requirements. That's a really rare skill. And if you find someone like that, you might not be able to afford them. So that's been a challenge for us.
Well, and a lot of that skill, that understanding, that ability to do the translation is experience-based, right? So when I first started working, I worked in nuclear, for Westinghouse, and then I worked in Carnegie Group, and I did, military transportation. So a lot of that understanding comes from working in an environment for a while. So it's hard to find that straight off the street, I think.
Yeah, I second that. That's a key thing, is having data analysts who can actually talk to clinicians and have a certain amount of understanding about clinical workflow, especially when they're dealing with quality improvements things. And I think physicians just don't also don't have the skill set sometimes to be able to communicate effectively with data analysts too. Like, they don't know what data they want. They really don't know what analysis they want. They just say, they come up with this project, and there's a lot of miscommunications, and it ends up sometimes with like garbage in, garbage out type thing scenario, and both sides get kind of frustrated. So I think one of my roles is actually to kind of help be that in-between person who can kind of communicate with both sides.
Yeah, I can certainly co-sign on all of that. And I think you're all right that the folks who get into clinical informatics and really do that translation role well, that a couple of you referred to, are sort of unicorns, right? Because you don't really get the luxury of sitting in a cubicle all day and just coding and not talking to anybody. You really have to be able to almost have a split personality where you can do that, but you can also have that really collaborative, team science kind of spirit, basically. So it makes perfect sense. One thing that we really wanted to focus on this particular panel is the fact that the informatics field clearly has a lot to gain from an increased focus on workforce diversity and inclusion. And based on your experience, what are some key steps that you think the informatics community can take to attract and retain diverse candidates for career and educational opportunities?
I think I can start. I think a big part of that is being more proactive. For instance, going after the math majors at HBCUs, for instance, and getting them hooked, because a lot of times they don't even know that the field exists, or like informatics or data analysts. So you get them in the first and second year, they're computer science or math majors, and you expose them to the field, and you kind of get them hooked on research and healthcare IT, and through actually maybe even shadowing physicians and actually seeing what clinical workflow looks like, having them being maybe shadowing a research team in the CTSA doing a project, doing a translational project. So I think that early exposure kind of gets them kind of motivated and excited about going into informatics or data analytics.
I definitely agree. Like when I was younger, you can't see me. But when I was younger, I interned at Westinghouse and then I ended up working there as my first job. So I think those internship experiences really helped to shape, because originally I wanted to be a physician, but because I interned at Westinghouse, I thought I was more of an engineer type person. So I think those types of experiences and exposures are critical to bringing people into the field. Here at Pitt, we do have some summer programs. We have a Cosby program and another program, but one of them is geared towards minority students. So I think things like that are very helpful. And you got to get them when they're young, because if they find out how much money they can make, they're not going to be with you. So you got to kind of hook them while they're young, though.
That's true. Yeah.
I
think go ahead, I'm sorry.
I was just going to say that I think another option is to promote remote work to maybe ease costs of commuting and parking. And I think that's worked really well for us. Unfortunately, from the pandemic, we learned that remote work is possible for healthcare IT, and we work a little bit harder than perhaps we did before. We're on all the time. But the flip side is we don't pay for parking anymore, and we don't have to worry about the long commute. And perhaps, since we're an urban hospital, we could really take advantage of people who live nearby and really train the talent within and through internships and subsidized degree programs. I think that would be helpful as well.
Yeah. And I think also getting the workforce and leadership to understand that having a diverse workforce makes for better science, for instance, because, I'll give you kind of an anecdote. Like my wife is an infectious disease physician who does basically epidemiology in the aging HIV positive population. And they're kind of getting all the diseases that older people kind of get. And she was working with one biostatistician who was looking at the burden of atherosclerosis in the HIV population. And he did his analysis and he found that actually African Americans had lower atherosclerotic burden than white patients. And he just couldn't believe it. Like his assumption is that African Americans always have bad outcomes. And that was kind of his assumptions about his bias, going into a lot of his research. And he really, even being a biostatistician, he didn't believe his numbers. And he had to go through the calculations himself. So I think there's a lot of work that we could do in teaching people health equity and disparities within the research workforce now and the informatics workforce now, just so they kind of understand and think about that when they're actually doing research, thinking about studies and how they're designed. Because I think that actually, that kind of bias, bleeds into the research and leads to bad science, which kind of leads to suboptimal medicine once that science is actually applied to patient care.
I think that's a really powerful anecdote and really ties in with some of the algorithmic bias focus that I think we have additional conversations as part of this conference, just because that is such a critical issue right now. But you're absolutely right that the people doing the science have an enormous impact on the actual scientific outcomes, even if they don't think that they do. And one additional thing that I might add to tie together what you all said is it sounds like there's a lot of emphasis on internships, which I agree seem like a really great way to get folks in the door. One additional thing I might add is that I think we should need to start a culture of paid internships and decently paid internships. No one's going to get rich off an internship, but if you can pay your rent and your cell phone bill with your internship money, and that enables you to not have to take one or two other jobs at the same time, I think that that will also enable people who may not otherwise have been able to do that kind of experience in the academic environment to go ahead and do so. So I think that at our universities, figuring out ways to make that happen, and maybe going around the sort of traditional culture of, yes, well, you get paid in experience, or you get paid because you get to make relationships with these very, sophisticated PIs. I think cash helps too. And I think
my internships were paid.
As they should be, they should be. Okay, wonderful. So moving on to a different topic. This is a question that I get a lot from students, and I have a feeling you probably get it a lot too. But what do you think are the most critical skills, 3 to 5 things that the most desirable informatics candidates in the academic space possess? And as a sort of a second part to that question, is that going to change in the next 5 to 7 years, that list of skills? Are there going to be different things that we need to start looking for that maybe we're not looking for today?
I think there's, of course, the hard skills. Can you program? Can you, those types of things. But for me, I think it's the softer skills that are more important. Are you flexible? Are you creative? To what extent are you able to recognize patterns and things of that nature? Because that's what we're essentially doing. We're looking at stuff and abstracting concepts and finding patterns so that they can be programmed. And so I feel like that is like the most important skill for somebody. Are you curious? Aside from the programming skills, I think is what I would look for the most.
Yeah, I agree with that. And I think, again, just emphasizing, I think communication skills and people skills is very important, because you're going to have to interface with a lot of multidisciplinary team who have kind of different levels of knowledge about kind of data analytics or informatics, and being able to explain things in a way that everyone can understand it. Like, it's really straightforward. There's no ambiguity. And I think that's really, really important. And I think that's something that will just never go away. I think 5-7 years from now, I think that skill set will still probably be really, really important.
I think that to add on to that, a knowledge of data standards is important as well. We've done so much AMR data analysis without using common standards or ontologies and trying to share that data among other academic sites and externally. We know now that is a huge effort and difficult. So someone who comes in with a knowledge of standards is really important. I think also, at least at Hopkins, improved skills in data analysis, maybe not just for an informatics team, but for the research community at large. A lot of our more experienced researchers use a somewhat outdated analytic tool. Would really like to pass along knowledge about how to use more advanced tooling, especially in the world of natural language processing, machine learning. We have so many clinical documents that really could use to be annotated and mined more effectively, and the tools that we're using now are just not effective or as effective as others could be. So teaching those tools in upcoming courses and getting the word out about the new tools, I think would be very helpful.
Yeah, I certainly agree with that. And in some ways, I think that there are some skills that are easier to teach on the job than others. And Bonnie, I think what you said about data standards is really important because I would say that's one of the hardest things to teach. And if someone comes in with no knowledge of data standards in healthcare, even if they're brilliant, which of course so many informaticians are, that's a long walk up the mountain to be able to be productive if you have no existing knowledge of data standards. So that may mean that it's up to folks who are teaching informatics to ensure that their students come in with, or leave the program rather, with a really good foundation and those kind of basics. All right, so based on your experience, how can institutions encourage informatics faculty and staff to develop a true community of practice? And by this, I really mean, how can we share knowledge with each other in the field outside of the traditional mechanisms of conferences and publications? And I will say, Bonnie, I'm hoping one thing that you would be willing to talk about is your adjunct program, because what you have described to me in the past is a lot of sort of knowledge sharing and cross training that I think is really would be informative for this audience.
Right. Well, when I was preparing for this session, I jotted down a few notes, and I think conferences and publications are of course wonderful ways of sharing knowledge. But I believe that most faculty and staff appreciate the one-on-one or small group approach to learning as much, if not more, than conferences and publications. In my experience, and I'm guilty of this as well, I don't often have time to attend conferences and read publications. Shame on me, but it's a reality. At Hopkins, like I mentioned, we have created this adjunct group. We've also been created a new approach to information sharing by organizing grand rounds approaches to information dissemination. I think that's rather popular. For example, we began a data scientist grand rounds. So we hold small focused work groups, and we spend time establishing some topics that we discuss at each meeting. We go through all of our data analytic teams and invite participants to join. And we also offer hands-on or real-world use case analysis. So between the adjunct program, when we meet on a monthly basis and share actual challenges and successes, to this grand rounds approach to informatics, I think that creates a more collaborative community where people know each other. They can ping you separately. They can get together in work groups. They learn from each other. We can share code. We can share best practices in a Microsoft Teams type environment. So we're still evolving, but the feedback has been really positive, and we get to know our staff and collaborators better that way, I think.
Yeah, at UNC, and we have the Clinical Informatics Fellowship. A big part of that is actually they get to meet and greet all of the leadership in ISD. So everyone from the Chief Information Officer to the CMIO, and all the leadership kind of in ISD and also in NC Tracks. We've also developed like a monthly meeting with our cohorts in the Carolina Health Informatics program, who are basically kind of PhD postdoc types, also doing biomedical informatics and sharing projects and sharing ideas and areas for collaboration. So I think the being at a big institution like UNC, I think a lot of times people work in these kind of silos, and a big part of I think of my job is to try to break down those silos and have more communications between people, and I think kind of make for a more collaborative environment.
I guess I think that one of the things that we have to figure out is how to kind of turn down the competitive culture that we are in right now.
Sure.
Everybody is kind of, doesn't want to share their work or see other people succeed because it's such, I guess, competitive, grant culture, but we have to figure out a way to kind of get past that so people are more willing to share. Because I think, you know, of course, the more we share, the more we understand what others are doing. You'll implement it in your work and they'll implement some stuff in their work, and it'll all be better for it. So I think we got to turn down the competitive culture a little bit to be able to amp up the sharing culture.
I think that's a wonderful point, Michelle. And I also think that even if you do have a sharing culture, it needs to be a culture of sort of proactive documentation, so that you're not just putting a bunch of code in a GitHub repository and saying, oh, I shared it, it's public, right? If nobody can use it and there's no documentation and there's no sort of actual effort put in to make sure that other people can use what you've put out there, then I'm not sure that you really get to say you shared it. And I think if we can all move to a place where we are truly supporting other people in using the work that we put out there, then that's when we can truly say that we're sharing knowledge as a community of practice. So let's move to talking about students, and Carlton, I'm hoping that you'll talk a little bit about a little more about the fellowship program specifically, because I'm interested in how you all think that we can better get students prepared for careers in informatics, either as staff or faculty, other than the internships that we discussed.
Okay, I think from as far as faculty goes, you know, it's interesting because our clinical informatics fellowship is basically kind of specialty agnostic. So currently we have 4 informatics fellows, 2 of them are emergency medicine, 1 is psychiatry, and the other is a hospitalist. And we see, I mean, a big part of their training, again, is getting to work side by side with informaticists like in ISD and data analysts in ISD on real world projects. And I think it's very interesting because I think they actually learn from each other, because obviously they, the fellows learn kind of the technical skills, how to do SQL programming and Python programming and all that good stuff. But I think that analysts also kind of learn from the fellows about kind of the, you know, the clinical environment and the clinical setting, and they can give some context to the data they might be analyzing or the project they might be working on. So I think it's kind of a win-win situation. And the fellows really get the, you know, develop skills about how to communicate with both sides, how to, you know, communicate with clinicians and communicate with informaticians and data analysts, and kind of, you know, bridge that gap between those 2 cultures. So I think it's kind of one of the strongest points in our program, is that, so because we're so embedded in ISD, we just kind of work side by side with them and really get to know the culture, really get to know them, and they really learn a lot from us as well.
I co-teach a course within our master's program. I mentioned earlier, informatics training, and this was my first year teaching the course. But what I noticed is that most of the course participants were either clinicians themselves or they supported clinicians in health IT. And I feel like we can really make a difference by emphasizing to them the knowledge of sophisticated data extraction, analysis applications and tools, but also just simple concepts about how you identify a cohort of patients. I think that's, if we could continue to emphasize that type of these questions, curiosity, and really use maybe common data models like OMOP for cohort discovery and sharing. I think if we can, you know, to get students better prepared for careers in informatics, really understanding the sophisticated tooling that's available to them, and get away from spreadsheets and manual chart review. So I think that I think we're moving toward that, but just really understanding the whole clinical research life cycle as well, and knowing where you are in that process and what tools you and services are going to meet your needs the best. So the navigator is important, helping people understand how to get from start to finish, but also taking it upon yourself as a PI or a fellow to understand the technical aspects of your project, identify the data you need. So we're getting there, but that's one of the challenges.
I think that's certainly true as far as tooling goes. And another thing to consider that's connected to that is the new world of synthetic data that is now available, because enabling students to actually work with something that looks like the data they might see when they actually have a career in this space is going to give them wonderful practice, really important practice.
Yeah, that's especially true in like machine learning, is really having kind of a corpus that you can just kind of, that's been de-identified or made up, that people can work on. That's kind of one of the biggest barriers in teaching machine learning.
Absolutely.
Yeah.
We have a synthetic data set that is really more discrete than clinical notes that are de-identified, but we offer that as part of the training program. Request access to the synthetic data set, plug it in, Python, try to write some code. Let's walk through the scenarios together. I think the master's program is very carefully integrated in with our precision medicine program, so we can quickly demonstrate how to extract data and then implement it. And if a Hopkins researcher wants to take advantage of precision medicine data, then he or she has already been trained to access that data.
Yeah. And I also think kind of machine learning, that whole area of research, I think it also forces kind of informaticians and data analysts to really understand or make an effort to kind of understand the clinical context of a lot of the data, because you're working with free text data and understanding context when you're trying to pull certain information out of free text data. It kind of forces them to like collaborate with clinicians who can kind of give them that clinical context. It's not like working with numbers. So it's kind of a very different world.
Absolutely. I'm going to take a question from the chat, and if others have questions that they would like me to present to the panel, please feel free to go ahead and put that in the chat and I can collect them. But the question here is, what do you see as the future balance of clinician informaticians, folks who have an MD or an RN, and then informaticians without clinical backgrounds?
Good question. I think that, and from my perspective, I think they I think there's a synergy there. I think that the clinical informaticians have a stronger, especially with practicing physicians, have a stronger understanding of kind of what the research questions are. There, a lot, this is very interesting. A lot of the research and quality improvement projects I'm involved in are basically physicians going about their job and just looking at these, coming across these patient safety issues and quality improvement issues in their daily lives. And they say, like, this is just annoying. And this is really, this is something that needs to be dealt with. And a lot of times they come up with the clinical questions, and they have certain amount of clinical, or, the technical skills in informatics and programming and things like that. And I think they would probably rely more on the kind of the non-clinician informaticians who probably have more technical knowledge about, like, say, machine learning and NLP and things like that, than the clinical informatician. So I think there would be kind of great collaboration between the two. I don't think I think that both are needed.
Yeah. I think if the more clinicians that we get involved, I think the better, because they know the workflow.
Yeah.
And you need them to be able to see the data from both sides, right? So they are actually looking at the data and the processes from the user's perspective.
Yeah.
We are looking at it from the developer's perspective. And I think you really need that user perspective to push hard on those who are not in the do not do that as a daily thing to keep us in line. Because if you leave developers to their own devices, they will create a bunch of great stuff, but it won't be usable.
Yeah.
So as long as we're doing this, we really need the clinicians to be a big part of it to help drive it to a solution that's worthwhile and usable and understandable.
Exactly.
I think some informaticians think that the data they receive will be easy to analyze and derive meaning from, and then they're surprised when they get a large tranche of data that doesn't have a lot of documentation to it, and they have a lot of questions, and then they're intimidated, because if you misinterpret or join two tables that shouldn't be joined, then you may not know that your results are false until it's too late. So I think the informaticians that have the technical skill also need to understand the workflow. So it's, yes, both ways. But they have to know what they don't know, which is sometimes difficult to convince people of. Oh, I can analyze this data, no problem. It's relational. Yes, but there's a lot of missingness to clinical data that they might not know. There are a lot of nuances with understanding.
Nuances, yes.
Yeah.
That's the biggest thing I think with clinical data, is it's very nuanced. You have to layer on that this is secondary use, that we're using this data. This, the reason why a physician puts in one code versus another is the clinical practice, or how they will be paid for it, or how it got upcoded by the coders. So there's a lot of things that influence the data by the time we get it. So I think we have to be aware of it. And I think knowing that it looks different on the two different sides is important.
Yeah, and an important, for instance, example where you kind of need both skill sets is in the work I've done in kind of EHR usability. So we have an informatician, actually his background's in industrial engineering. He's a PhD in industrial engineering, he's Lucas, Missouri. And he's done a lot of work with radiation oncology and also Epic EHR, and seeing and showing how optimizing user interface will actually reduce the amount of errors made by clinicians when they're actually doing their tasks. And so you kind of need that clinician there who understands the workflow and understands the workflow in the EHR in order to get research like that done. And you need both sides. You need someone like Lucas, for instance, who knows the methodology as far as how to measure things like cognitive workload and things like that while you're doing tasks, and the analytics behind that. So I think there's a lot of synergy between those two types of informaticians.
And there's a great comment from Mark in the chat that I think really underscores everything that folks have said about, trying to use the data to differentiate between a predictor of disease and a marker of disease. That's a really nuanced thing that really requires that clinician informatician collaboration. I see Dr. Ford has his hand up. Would you like to ask a question?
Yeah, I was just going to say that, obviously there's a lot of issues in workflow. We're doing the same thing with research corners, and some of the things that I didn't hear today that we might be looking at more formally around the team science framework, right? Is, does a person that is in the data science role, do they have the tools and do they know how to ask for help if they don't feel left out to dry, right? Are they being respected in their role by the people they have to work with? And are they connected to that final product of improving care that seems to be what keeps them, at the academic side? So is this kind of like, they asked me for the data, I delivered the data, and then maybe I learned out 2 years later that something happened with it? You're not creating that explicit connection to the value. And the other thing that Michelle mentioned, which I do think we have to be careful about, is, how do we understand that university culture that, you know, in the company side, generally, there is not as much internal competition because the goal is to get a product out. And then you come to academic and you feel it's a little bit more, I don't know, less profit motivated, but then you find that you have internal groups that are competing with each other. And it's not exactly what you thought it was going to be. And we, you know, those are some of the things. And then, you know, career ladder, certainly on the research coordinator's head, that's a huge issue that everybody's trying to figure out. Unless you accept a certain amount of turnover, and then you really have to go to the model of much more increased training in the beginning, right? Okay, they're only going to be here for so many years. I'll accept that. But they have to be able to and be productive quickly. So we're going to, you know, do a 1 or 2 month orientation or whatever it might take. And that I think fits in a little bit with what, you know, Phil should do is, are they connected to how care is provided? And see it and feel more connected to it. And I know something close to that on the clinical EPI program in our School of Public Health, where we had people that were graduating with a PhD in clinical EPI and have never been in a doctor's office, have never seen data is collected, have never seen what an EKG, how it's done, where it's looked at. And we really found that to be very helpful to take somebody who has, you know, sort of, I understand clinical, I want to see the data, but make them more comfortable about understanding how the data really is connected.
Yeah, yeah, I second that. That's one thing that actually the Carolina Health Informatics program actually does with their master's and PhD programs. They actually had them where they were shadowing me in my outpatient clinic and also in the hospital. And I could just kind of go through my day and how I interface with the EHR and the health IT, you know, what my workflow is like and things like that. And I think that really gave them insight. And part of the project was, you know, given the workflow and the limitations in the EHR, what would you do to kind of make the system better? How would you change the workflow? How would you change the interface and the EHR and things like that? So it really made them think about the clinical workflow, and they were kind of, you know, thinking about how you would redesign an interface on an EHR, for instance. So I think that's really, really important.
Well, I see that we are at time, a little bit over. I want to thank all of our panelists for a really great discussion and some really wonderful insights that I think we can all use. And I want to thank everyone who attended and asked great questions. And I hope that you enjoy the rest of your day at this conference.
Okay, thank you. Thank you, everyone.
Thanks,
Thank you.
everybody.
Thanks.